Thank you so much for having me today. Thank you all for coming and sharing your lunch hour with me. So as Nikki mentioned, I'm the director of our GI Behavioral Medicine program here at Northwestern. And in our program, we treat patients with a variety of chronic GI conditions by providing psychological and behavioral interventions. And so today I'm going to be focusing on irritable bowel syndrome because this is a condition that impacts a significant number of women in our country. And so my goal for today is to give you an overview of what IBS is as a condition and discuss the role of both the brain and the gut in contributing to symptoms for women, and talk about some of the sex and gender-based differences of the condition, and then also fill you in on the behavioral treatments we offer in our clinic. So I'll be discussing cognitive behavioral therapy and also gut-directed hypnosis as two evidence-based treatments that we provide. And then finally, I'll leave you with some resources that could potentially be helpful to you or your patients for managing symptoms of IBS. So I'll start by giving you sort of a snapshot of our program. Here at Northwestern, we really believe in multidisciplinary care for patients with chronic GI conditions, particularly irritable bowel syndrome. And so in our clinic, we really work closely together to collaborate in the treatment of patients. And so we have 2 health psychologists in our clinic currently. We work closely with our gastroenterologist who specializes in functional bowel disorders, as well as our registered dietitian, and also have a liaison and health coach that provides ongoing support to patients. So in terms of IBS, I'll give you sort of an overview of what the condition is. As many of you may already know, we consider it a functional GI disorder. So what that means is there's no structural or physiological abnormalities that can be identified that account for the symptoms. So this is different from something like Crohn's disease or celiac disease, where there's measurable abnormalities, or either seen on a colonoscopy or through blood tests that can identify the disorder. So with irritable bowel syndrome and other functional GI disorders, we really believe the dysfunction is at the neurological level of the gut, or the gut's nervous system, which is its own nervous system called the enteric nervous system. And I'll be speaking more about how it's really a disorder of the brain's communication with that gut's nervous system. So we do have symptom-based diagnostic criteria that we can use. So if a woman is to be diagnosed with IBS, the most common diagnostic criteria are considered the Rome criteria. These were developed by experts from around the world. Again, it's a symptom-based diagnosis. The predominant symptom is recurrent abdominal pain. So it's predominantly a pain condition, but then it's associated with alterations in bowel habits, so either bowel form or frequency. Symptoms can be very unpredictable, lasting for days or simply hours, but the unpredictable nature of the condition can be very distressing for patients. And so patients can also be further subtyped based on predominant bowel patterns. So patients can receive a diagnosis of diarrhea predominant IBS or constipation predominant IBS, or some people have more mixed patterns where they fluctuate between the two. In addition to those bowel abnormalities, patients often report a whole host of other symptoms. For example, bloating is a very common complaint, especially for women with the disorder. About 75% of women with IBS complain of bloating symptoms. Also, patients often report fatigue, nausea, and other abnormalities with bowel functioning, either an urgent need to rush to the bathroom or incomplete evacuation. So there's significant cost and healthcare burden associated with this disorder. It's highly prevalent, so it's estimated to affect 10 to 15% of the US population. And for outpatient gastroenterologists, patients with functional GI disorders comprise up to 30 to 50% of their practice. As you can see here, if you work in primary care, it's one of the most common diagnoses you see in your practice as well. And it's highly costly as well. So this is a difficult to manage condition. And so patients are often seeing multiple specialists. They're coming in for repeat office visits. They're trying multiple medications, maybe undergoing multiple procedures to try to discover, the underlying cause of this or a solution. And so there's significant healthcare dollars spent on this. And also, because of the impact on functioning, there's significant loss of work productivity as well. So as you can see, second only to the common cold and accounting for the most missed work days. And unfortunately for women, for all patients, there's an increased risk of surgery with the disorder. But an example of this is for women, you're twice as likely to have undergone a hysterectomy if you have a diagnosis of IBS. And so this speaks to how, the lack of effective treatments and the health-seeking behavior that's associated with this can actually be somewhat harmful for patients. So I'm focusing on IBS today because it is more prevalent in women. There's actually a 2-to-1 prevalence women to men. Worldwide, prevalence rates are estimated to be around 14% for women. And this may be in part because women are more likely to seek healthcare services in general, so they're more likely to be talking about their symptoms. They're more likely to be presenting to their physician's office, looking for solutions to this. But there also are likely some true sex-based biological factors that are playing a role as well. And I'll go into more detail about those later. The symptom profile also looks a little bit different for women. So women are more likely to have constipation predominant symptoms. They're also more likely to have associated symptoms of bloating and fatigue, and also have a more severe clinical profile. So more severe symptoms as well as more severe impairment in quality of life. And for all of our patients with IBS, they report significant quality of life impairment. One international survey of patients with IBS found that patients were willing to give up 25% of their remaining life to be symptom-free. And so that really speaks to the debilitating nature of this condition. And the graph on the left here is from an IBS specific quality of life measure and indicates some of the domains of functioning that are most often affected among patients with IBS. And as you can see, it really permeates sort of all aspects of life for patients. They're often reporting that they feel as though they're very much restricted in what they can do because of these symptoms. Remember, the symptoms are very unpredictable. You never know when you're going to be hit with a bout of diarrhea or painful bloating or gas, and so patients become anxious about eating, especially in social situations. They become worried about even, being able to get to work, getting stuck on traffic on the freeway, not being able to have access to a restroom, flying on an airplane. Some of these everyday situations we may take for granted become very stressful if you're living with this condition. So we don't know the exact cause of the disorder, and we really find it most useful to look at this from a biopsychosocial framework. And so we really believe that chronic symptoms of IBS are caused by this interaction between abnormalities of gut physiology with aspects of our central nervous system functioning. So we don't believe it's simply a stress-related disorder. There does seem to be evidence of some true physiological abnormalities of the gut. So whether it's alterations in the gut microbiome, low-grade inflammation, altered motility, some sort of abnormalities that then are aggravated by certain psychological or cognitive affective processes. So certain types of anxiety, and also difference in structures of brain functioning that influence how those signals from the gut are being interpreted. And we refer to this as the brain-gut axis. And so the brain-gut axis is this bidirectional neural pathway linking the cognitive emotional centers of the brain with our gut's nervous system, again, this enteric nervous system. And when there is dysregulation in this pathway, it can contribute to ongoing chronic symptoms of IBS. And so I'll be touching now on some of the mechanisms which we believe may contribute to that ongoing dysregulation for patients. So the first is the influence of stress. So, we all know that stress impacts our GI tract. So even if we don't have IBS, we've all experienced, a stomach ache before giving a presentation like this, or, butterflies before an important meeting or a first date. And that's because our gut feels the effect of acute stress. And there's even been evidence that for patients with IBS, there are some abnormalities in their stress response, the stress pathways of the brain. There's evidence that there's some abnormalities in the autonomic nervous system arousal, that it's being activated at lower thresholds than it is for the average patient. And so those abnormalities are causing further aggravation to the GI tract and contributing to gut symptoms. And patients are acutely aware of this. They're often telling us that, symptoms can be triggered or at least worsened during stressful situations. So another contributor to this dysregulation between the brain and the gut is what we call visceral hypersensitivity. So this is one of the hallmark features of IBS. It was first discovered through some experimental studies many years ago where they inserted a balloon catheter into the rectum of patients with IBS, and they found that patients experienced significant pain and discomfort at abnormally low levels of pressure from that balloon. This is compared to healthy controls where that same degree of pressure in the rectum or intestines was perceived as very mild, or there was minimal pain from it. So it seems that the nerve endings of the gut's nervous system, they're overfiring in response to normal GI sensations. And so that's why maybe normal amounts of gas in the intestines or normal movement of waste through the colon can be perceived as highly painful and uncomfortable for someone who has IBS. And you can imagine when that hypersensitivity is paired with anxiety or patients being very kind of tuned in with their body and tuned in with their symptoms, that can really contribute to aggravated symptoms. So there also seems to be some dysregulation and central nervous system networks that interpret these pain signals from the gut. So there have been fMRI studies that have discovered that in patients with IBS, their brain's not able to downregulate these signals from their gut effectively. So in healthy controls, when pain is stimulated in the colon, it triggers an aspect of the limbic system, the anterior cingulate cortex, to downregulate that pain, and that part of the brain is not firing in these studies with patients of IBS. And so there's that true sort of cerebral dysfunction that may be playing a role as well. And finally, I think this is sort of a nice model of this complex interaction between psychological components and other risk factors with the gut physiology to explain IBS. So post-infectious IBS is characterized by individuals who experience an acute bout of gastroenteritis. And for about 10 to 20% of patients who have this, even once they recover from the gastroenteritis, they go on to experience chronic continued pain and altered bowel habits, and this is characterized as post-infectious IBS. Interestingly, there seem to be certain risk factors for what patients develop this versus which patients don't, and some of the risk factors that have been identified are anxiety at the time of infection, somatization, as well as being a young woman seems to be a risk factor as well. So in terms of understanding, why we have this increased prevalence among women, why is this a women's health issue? Unfortunately, we don't have a lot of clear answers on that, but we have some hypotheses. There does seem to be a true hormonal component. There's a great deal of evidence for this. So the age of onset for this condition is most commonly late teens to early 40s. So this is during women's reproductive years. And so a time of certainly hormonal shifts, and so that speaks to likely a hormonal component. Also, any of us who have been pregnant know that our GI tract slows down during pregnancy, and so that also speaks to the role that progesterone plays in altering gut motility. And then also, there does seem to be an influence of sex hormones on pain sensitivity in the gut. So again, remember these, the classic visceral hypersensitivity studies with the rectal balloon distension. So women actually report even more pain at lower thresholds than men, and also during the menstrual cycle, those pain thresholds are even lower. And so it seems that sex hormones do influence that experience of pain in the gut. fMRI studies have also shown that women are processing pain in their brains differently than men. And so that speaks to this central component or central processing component as well that may be relevant for women. And then finally, women respond differently to certain medications. For example, certain serotonergic agents seem to be more effective in women, and so that neurotransmitter may also be influenced by certain sex hormones. In addition to these sex-based biological factors, we also believe there's likely sociocultural factors that are playing a role as well in contributing to this increased prevalence among women. So as I mentioned before, women are more likely to be seeking healthcare services in the first place, and so that may account for some of the higher numbers. Women also experience more stigma, and there's more societal norms around bowel symptoms. Typically, women find them to be more embarrassing. There's more stigma around talking about your bowels and bowel symptoms. Women tend to have more sort of perfectionistic views around body image, maybe are more disturbed by symptoms like bloating or impact on their body image because of the symptoms. And so that can create more distress around living with this condition and may contribute to worsening symptoms. We also know that women are more likely to engage in catastrophizing related to pain, even women without IBS, and we know that this is a risk factor for worsening symptoms, and so that likely plays a role as well. And then finally, abuse history. Any form of early life trauma or adversity is a risk factor for developing IBS later in life, and women are more likely to have experienced abuse, and so this may be predisposing women to the condition. And we don't know exactly why abuse is a risk factor. However, it seems that it likely plays some role in the development of the gut's nervous system. And so experiencing some sort of early life trauma likely influences maybe the gut's microbiome, contributes to visceral hypersensitivity, and certainly influences psychological factors and likely coping behaviors that may later play a role, even once the abuse has resolved or that trauma is resolved, may still be relevant in terms of how the woman is processing or responding to symptoms of IBS. So when we look at the psychological profile of patients with IBS, there is an increased rate of anxiety for women. So about 50% of our patients with IBS do meet criteria for an anxiety disorder. What we see most often is generalized anxiety disorder, and it often presents when we see patients in clinic as a significant worry related to their bowel symptoms. So whether access to a bathroom or appearing bloated or having gas. We see some panic disorder and also sometimes clinical depression. But I think it's worth noting that there's also a significant portion of patients that don't meet criteria for a psychological disorder. And many of the patients we see in our clinic here at Northwestern are psychologically very healthy. They've just maybe experienced distress and anxiety related to their symptoms more so than a more generalized mental health disorder. So what we tend to focus on more in our treatment and what's more relevant in terms of the presentation of IBS is what we call the symptom-specific anxiety. And so these are the psychological processes that are more specifically related to the GI symptoms. Examples of this are what we call visceral anxiety. So this is being very highly tuned in and having negative appraisals of symptoms in the GI tract. So even, again, normal or very minimal symptoms, our patients tend to be very highly tuned in with, aware of, and perceiving in a negative light. So for example, patients will say, I'm afraid of eating, and anything I eat, I worry it's going to make my bloating or distension worse. Or as soon as I walk in a room, I have to know where the bathroom is just in case I need it. And so there's this kind of hypervigilance, being highly tuned in with their body and with symptoms that can contribute. Also pain catastrophizing, so the tendency to focus on or exaggerate the painful stimuli and really minimize one's ability to cope and ability to manage the symptoms. So here's an example of what this actually looks like in terms of like a clinical presentation. So maybe, for an example, a patient who has dinner plans later that night starts to notice some cramping, some discomfort in their abdomen right before they're about to go out with friends. And then they experience this GI-specific anxiety. So they perceive the symptoms and they start to think, oh no, this cramping, this means something bad is going to happen. I'm going to have a terrible attack. Maybe I'll be in the bathroom the whole time. Everyone at this dinner is going to notice. They're going to think something's wrong with me or think I'm weird. This is going to be humiliating. And then in response to that anxiety, there may be some maladaptive coping. So just deciding to cancel the plans, not go to dinner, and instead stay home alone that night. And because of that increased isolation, maybe the patient begins to feel, be even more focused on their symptoms, feel more alone in this. So then they're reaching out to their doctor, pursuing more medical workup, pursuing more help for this. And so it's really this sort of snowballing effect that's perpetuated by the anxiety and also by the maladaptive coping behaviors. Other examples of this are catastrophizing, so, right, riding the L, being on an airplane. Again, these sort of everyday situations for many of us are highly stressful if you have IBS, especially patients with diarrhea predominant IBS. Just worry about making it to a bathroom in time, feeling trapped in situations. With the experience of pain, again, the catastrophizing is, viewing the pain as just unbearable, intolerable, wanting to just kind of avoid situations, call their doctor, wanting to seek out help. So again, going back to this biopsychosocial model, many of these psychological processes that I've touched on, we believe are relevant to the condition and contributing to this brain-gut dysregulation, really aggravating these GI symptoms. And so you can see how this really speaks to the importance of offering psychological treatments to address this component. The medical treatments that are only focusing on the GI tract or maybe the motility of the GI tract are missing an important piece of the picture. So I'll shift gears now and focus on our IBS treatments. As I was mentioning, medications are really ineffective in and of themselves at treating and managing this condition, especially for patients with more moderate to severe symptoms. Again, medications may simply help with the motility, so you can give someone a laxative when they're constipated, but it may not address the whole host of symptoms that patients are experiencing. So it may not address the bloating, it may not address the incomplete evacuation or the fatigue, and so patients often don't receive adequate relief from these single medications. Also, many of our patients are sensitive to the side effects of medications, and so they may not be able to tolerate some of the laxatives or some of the pharmacological treatments that are offered. And we also see a lot of young women in our clinic who just don't want to be on a medication. They are anticipating this being a chronic medical condition. They want to learn to manage it and don't want to have to rely on a medication for the rest of their life. And this is most true, again, for the patients with more moderate to severe symptoms. So if you take a look at the blue bar of the pyramid here, this is patients with milder symptoms. And so if you're in primary care and you're seeing a patient with mild IBS, simply providing them with some education, some reassurance, maybe some lifestyle modification, that may be sufficient to help them manage the condition. But when we move our way up the pyramid here and we're treating patients with more moderate to severe symptoms, and these are often the more chronic symptoms, that's when it becomes more important to incorporate psychological treatments and to really think about addressing this more from a multidisciplinary approach. And even the AGA at this point is recommending psychological treatment interventions for patients with irritable bowel syndrome, those who've not responded to standard medical care, or for whom psychological factors seem to be exacerbating their symptoms. So here at Northwestern, we really believe in offering evidence-based treatments. So in our program, the two psychological treatments that we offer to patients have both been supported through scientific research and are gut-directed hypnosis and cognitive behavioral therapy. So both of these treatments are really targeting medical symptom management. And so this isn't simply, supportive psychotherapy. It's not treating comorbid anxiety. They're really directed specifically at managing the IBS symptoms and addressing the cognitive affective processes that we believe are driving or aggravating the symptoms. And here in our clinic, I think it's notable that it's really considered standard of care to offer treatment with a psychologist. So with many of our physicians, when they're given a diagnosis of irritable bowel syndrome, they're given a whole range of treatment options, and included in that is to meet with a health psychologist. And many patients want to choose that option, again, due to a preference to not take medications and to manage their symptoms with a behavioral approach. And again, there's been extensive research to date to support the use of psychological treatments for IBS. And these studies really look at reductions in IBS symptoms as the primary outcome. And so we're not simply seeing reductions in anxiety, improved quality of life, although that happens as well, but we're seeing reduced pain severity as well as normalizing bowel habits as a result of treatment. And when we look at the specific number needed to treat for these psychological treatments, it's quite impressive. For cognitive behavioral therapy, we have a number needed to treat of 3. For gut-directed hypnosis, it's a number needed to treat of 2. And if we compare this to some of the medications that get a lot of advertising dollars and airtime these days, it's quite impressive compared to some of these other treatments. And it's also notable that with our psychological treatments, they're really quite durable. And so there have been some studies to follow patients 3 or 5 years after treatment, and the majority of patients are reporting sustained relief. So again, I think that's a great benefit over some of our medications because there can be, lasting changes that occur. So now I'll give you some more information on these treatments specifically, starting with cognitive behavioral therapy. Some of you may be familiar with this as a type of psychotherapy that's commonly used to treat depression or anxiety. It's really the gold standard treatment for many of those conditions now, and is becoming increasingly popular for use with medical populations as well and in chronic pain. And it's been specifically designed to target IBS symptoms. And so it's a fairly short-term treatment. It's really framed as, skills-based training. And so we're teaching patients coping skills, self-management skills that they can utilize on their own. So it's a series of 4 to 6 sessions with a health psychologist. And the treatment is focusing on modifying physiological arousal, so reducing that autonomic nervous system arousal, addressing the symptom-specific anxiety, and then also increasing flexible coping skills. So in terms of modifying arousal, there's different ways we can do this through CBT. The most common method is teaching diaphragmatic breathing. It's a pretty simple technique, but actually quite effective. So by shifting our breathing and learning diaphragmatic breathing, patients can gain control over that stress response. They can learn to elicit their parasympathetic response, which increases relaxation throughout the body, but is also getting blood flow and oxygen redirected towards the gut. Patients tend to really like this because it's something they can use in the moment to help counteract symptom flare-ups, reduce anxiety, and really give them a sense of control over their symptoms. Sometimes we also teach things like progressive muscle relaxation or guided imagery, but any of these skills that really help to engage that parasympathetic response and reduce autonomic nervous system arousal are very helpful. So the second key component in CBT is really modifying these negative cognitions that are contributing to the symptom-related anxiety. The first step in doing this is simply understanding, what are the trigger situations for a particular patient, what are the negative thinking styles, and how do we shift that thinking to reduce the anxiety. So this is an example from a young woman I was seeing in treatment, and she had constipation predominant symptoms with a lot of bloating, a lot of gas. One of her trigger situations that she brought into our treatment session that we discussed was going to a yoga class. This became very stressful. She used to love going to yoga, but now with her IBS, this was very stressful. She had fears of passing gas in the middle of her yoga class. And so we really broke this down to identify what are the underlying fears, anxieties, thoughts contributing to the anxiety. So fear of passing gas, others having negative judgments of this, thinking she's gross, this would be humiliating to her. She felt like I'd never be able to go back to the class, I couldn't handle this, so she would just cancel the class and not go at all. So through a process that we call Socratic questioning, where we challenge those initial negative thoughts, and we try to come up with a more accurate way of viewing the situation to reduce the anxiety, we helped her to come up with some alternative ways of thinking about this. So we do this through, evidence-based logic, asking, how accurate is this? Do you really pass gas every time you go? Does everyone really notice? How accurate is this thinking? Because if it's not entirely accurate, maybe you can let go of some of these negative fears. Also trying to take a perspective of someone else, sometimes putting themselves in someone else's shoes can be helpful for reframing the situation, and also just thinking about other outcomes. It's so easy to get focused on the worst case scenario when we're stressed or anxious, and so encouraging patients to see other possibilities for how scenarios may play out is important. So for this particular patient, what she came up with in terms of coping statements or ways of reframing this were, you know what, most of the things I worry about never actually happen. Everyone passes gas, even women. People aren't going to even notice, and they certainly won't care. They're not going to remember this the next time they go to yoga class. I've had other embarrassing things happen. I've survived it. Focus on my deep breathing, try to enjoy the class, and finally just let it go. I need to move on and not fixate on this. So that's an example of the cognitive reframing work. And then finally, through CBT, we really emphasize what we call flexible coping strategies. So there's been research to indicate that patients with functional GI disorders like IBS are more likely to use what we call problem-focused coping mechanisms. So they get very focused on trying to fix a problem, a stressor, trying to come up with a solution. And ideally, when we're facing stressors, we want to be more flexible. You know, problems that have a solution, yes, we want to fix them, but many of our stressors in life don't necessarily have solutions. And so in those cases, we need to learn to manage the negative emotions associated with a stressor. And so simply identifying when they have control, when they don't, and having a wide range of coping mechanisms they can use is very helpful. And you can imagine simply with coping with having a diagnosis with IBS, this is very important. Many patients get focused on, I have to fix this, I have to find a solution. Unfortunately, we don't have that at this point. We don't have a cure. And so some degree of acceptance over this being a chronic condition that they can learn to manage is an important part of the treatment. So I'll move on now to talk about gut-directed hypnosis, the other evidence-based treatment that we offer for irritable bowel syndrome. So hypnosis has actually had a long history of being used as a medical tool. Patients are sometimes surprised to hear that this is being used as a treatment for irritable bowel syndrome, but in terms of its use for chronic pain, it has a long history. Even before modern anesthesia was discovered, hypnosis was actually used for surgical procedures. And it's only been the last 20 or 30 years that we really have some good scientific support for its use with medical populations. And so it's been documented now to be highly beneficial for patients with chronic pain. It's also been used quite a bit with burn victims. It's been shown to reduce blistering and swelling following a burn injury. Also is effective at reducing postoperative pain and nausea following breast surgery. It's used with cancer-related pain. And then, of course, in our GI population, it's been used quite extensively. Even with children with functional abdominal pain, it's quite effective. So it was first developed for use with patients with irritable bowel syndrome by Dr. Peter Warwell. He was a gastroenterologist in Manchester, England, and he became interested in hypnosis back in the 1980s. And he conducted the first trial of hypnosis with his patients with fairly severe and refractory IBS and had very profound results from this. The treatment significantly reduced pain and helped to normalize bowel habits. And so there was a lot of excitement about these positive findings. And since that time, his group, as well as other research groups, have replicated those findings, and we consider it to be an effective treatment at this point for IBS as well as many other functional GI disorders. We even have specifically designed protocols that we can follow. One is the Manchester protocol developed by Dr. Warwell and colleagues, which involves 12 sessions with a hypnotherapist, and then also a protocol developed by Dr. Ole Paulson at the University of North Carolina, which is a 7-session protocol, and that's what we follow here at Northwestern. So here's a review of the randomized controlled trials examining the use of hypnosis for functional GI disorders. You can see that 7 of these studies have been conducted with IBS. It's also notable that, with these studies, as well as the research on cognitive behavioral therapy, that most of our participants are women. We don't really have sufficient men participating in our studies, which is really a downfall in terms of being able to examine sex and gender-based differences in treatments and understanding the condition, but also does give us some confidence in knowing that these treatments are effective for women, because most participants in the studies have been women. So we don't know the exact mechanisms of hypnosis, but we have some theories about why it's helpful specifically for IBS and for the gut. So the first is that we believe it really does influence gut motility. So being in that deeply relaxed state, in that hypnotic trance state, can really help to slow down the motility of the gut or normalize the gut motility. The graph here demonstrates, on the left-hand side, the pressure in the gut at resting and then during hypnotic induction. So you can see it has this sort of quieting effect on the gut. Also, hypnosis has been shown to normalize rectal sensitivity, so it does seem to influence that pain sensitivity in the gut. It also has influenced central processing in the brain, so it can modify some of those central dysfunctions. And it also can reduce autonomic nervous system activity. So part of the hypnosis is helping the patient get deeply relaxed. And so that's likely has a beneficial effect as well. And then, of course, there's psychological benefits from hypnosis. So even though we're not targeting anxiety, patients often report reduced anxiety, other positive effects from this. And so that's likely leading to improved symptoms as well. And I really do believe some of the hypnotic suggestions that are included in the treatment can actually sort of shift cognitive thinking styles that patients have related to their symptoms. So what is hypnosis? There's a lot of myths and misperceptions about what this is. So we define hypnosis as this verbally guided intervention that is aimed at encouraging this special mental state where we can facilitate psychological and physiological changes. So again, many myths that we have to address when patients are referred to us. So one fear that patients have is that they're going to completely lose control during hypnosis, and that's not at all true. And so even though they're being guided through this, it does require a therapist to guide them through the treatment, they're very much in control of the process. And so I often tell patients, you take this where you want to, you go as deep as you'd like, and you're in the driver's seat even though I'm guiding you through it. And your patients aren't made to do anything they wouldn't do otherwise. Patients also worry about whether they actually can be hypnotized or whether if they're not completely out, whether it actually worked. And there actually is individual variability in hypnotizability. It's sort of it's a stable trait we all have is how hypnotizable we are. So some people are just going to be naturally more susceptible to this than others, but that doesn't seem to correlate with how effective the treatment is. And so really, as long as the patient is open to it and they're committed, they're likely to benefit at least to some degree. So when we think about what a hypnosis session looks like, we can sort of break it down into these two components. So the first is really the induction. And so this is where we're guiding the patient and getting them very deeply relaxed. We're trying to encourage this hypnotic trance state. So we do this by using deep breathing, progressive muscle relaxation, narrowing their focus of attention, using a lot of vivid imagery. And so we're hoping that they can achieve this more relaxed state where their mind is going to be more open to hearing messages and suggestions to facilitate changes. And so the suggestions really come towards the end. And so this is what we consider more kind of the therapeutic ingredient of the hypnosis. So hypnosis itself isn't actually a treatment. It's like an empty syringe. It's the suggestions that are used that are really the active ingredient. And so for that active ingredient, we use metaphors, images, and therapeutic targeted verbal suggestions aimed at addressing the symptoms the patient is presenting with. So, for example, with a patient with IBS, what this may look like is having them, helping to encourage this relaxed state, and then having them visualize a healing, maybe magical medication that's coating their stomach, coating their intestines, creating the strong protective coating to help reduce any irritation, protect them from feeling upset inside, and then messages about lasting changes they're going to experience as a result of this. So, telling them that their symptoms will be much milder in the weeks to come, or they'll go much longer periods of time without even noticing discomfort in their bowels. And our IBS protocols have really been designed to specifically target the symptoms of the disorder. So for example, there's messages about regulating smooth muscle activity because there's just this dysregulation of motility with IBS. We want to have messages about encouraging normal bowel habits. For example, your bowels will function in all situations with a healthy, quiet, natural rhythm that's comfortable and soothing and hardly noticeable at all. Or reducing the impact of stress on the GI system. So imagining they're relaxing in a warm, safe mountain cabin, and they start to feel as though nothing can disturb their deep comfort, like nothing can upset them inside or cause them discomfort or pain. Or reducing gut pain perception. Sensations that used to be uncomfortable now increasingly feel just mild and soothing and don't bother you at all. And also increasing patients' sense of control over symptoms. We really want to increase this sense of self-efficacy, sense of being able to manage symptoms on their own. So a message like, you feel confident in your ability to keep strengthening your body's natural resistance to stress and discomfort. And again, we have significant scientific support for the use of hypnosis, specifically with IBS. And it's also notable that these studies have identified benefits beyond simply the IBS symptoms. And so in addition to improved bowel habits, patients also report improvements in what we call non-colonic symptoms. So the comorbid fatigue, sleep disturbance, back aches, muscle aches often improve as well, in addition to improvements in IBS. So I often joke with patients that the only side effect they're going to have from their hypnosis treatment is going to be a positive one, unlike many of the medications. So to summarize, the psychological treatments we have, they're short-term, only about 5 to 7 sessions. They do require some sort of home practice so that the patients are incorporating these skills on their own. The psychological treatments are really targeting the central processing deficits that we believe are contributing to the symptoms. And these treatments can be provided by a health psychologist, and they're typically covered by health insurance. And so as health psychologists, we're able to use what we call health and behavior codes. And so we can bill the treatment to their medical benefits under a diagnosis of IBS, so it doesn't have to go through the patient's mental health benefits. So this makes it less stigmatizing for patients, and also patients often prefer this in terms of better coverage and unlimited sessions with the psychologist. Okay, so finally, I'll leave you with some resources in case you're interested in seeking out additional information. So if you're a provider and you're interested in learning more about psychological treatments and how to discuss these with your patients, this is a really nice article written by Dr. Paulson, a psychologist at the University of North Carolina. He's extensively researched these treatments and developed the hypnosis protocol for IBS. And so this is an article written for physicians that gives an overview of the research that's been done on these psychological treatments and examples of functional GI disorders that the treatments are effective for. When patients are looking to seek out more information, the International Foundation for Functional GI Disorders is a really great website. They are a patient advocacy organization specifically focused on functional GI disorders. And so they have a lot of great literature for patients explaining IBS, explaining the role of stress in IBS, and also, as this example shows, really walking through these treatments in more detail so that patients can obtain that education. And then finally, for patients who are interested in more kind of self-help resources, who maybe not be at a point of needing to see a provider for treatment, there's some good books out there. The Controlling IBS, the Drug-Free Way is by Dr. Jeff Lackner, who contributed to the development of the CBT protocols we use now for treating IBS. Also, Master Your IBS is a very nice workbook developed by a group of nurses at the University of Washington. And again, a patient can kind of walk through it on their own as a way of learning some of these CBT skills to help manage their symptoms. And then finally, GastroGirl is a web platform that offers a lot of education, listservs, and also health coaching support for patients, specifically women. So in terms of future directions, when we're thinking about understanding the impact of IBS on women, again, we don't really have sufficient men enrolled in our studies to look at gender and sex-based differences. And so, that really needs to be the next step in terms of our research. And also, really accounting for the hormonal component and measuring that in our studies so we can better explain the role that that's playing. And finally, some take-home points. We know that IBS is highly prevalent and disproportionately affects women. It's primarily a disorder of brain-gut dysregulation. Our behavioral treatments are targeting IBS symptoms, not a psychological disorder. These are short-term and they're skills-based. And then most importantly, if you're a provider, I think the most important take-home message is, refer your patients early on. What happens is when patients aren't getting treatment and they have many kind of failed treatment experiences, this leads to more psychological distress, a worsening clinical picture, and it becomes harder to treat and manage later on. So bring up this concept of stress and brain-gut playing a role, and consider referring to a health psychologist. And this is the contact information for our program here at Northwestern.